Being the second day of our scientific program, let us start today's session with evaluation of organicity and pointers on preparing for a neurology short case by Dr. Migita de Cruz, ma'am. She's completed MD, DM in Geriatric Psychiatry, Associate Consultant of Psychiatry and Behavioral Medicine, Kerala Institute of Medical Sciences, Trivandrum. The chairpersons for this session are Dr. S. Ananda Krishna Kumar sir and Dr. R. Sabreen Sajeev Rose sir. I welcome you to the dais. Dr. S. Ananda Krishna Kumar sir has completed his MD DPM and is the professor and head of Department of Psychiatry in Madurai Medical College. He has done his MBBS in PSG IMSR, Coimbatore, and MD Psychiatry and DPM in Madurai Medical College. He is the postgraduate teacher for the past 16 years and has been awarded the Best Practitioner Award at TAN PsyCon 2008. He has published 5 publications in national and international journals. He is the quiz master in many TAN PsyCon for undergraduates and postgraduates. Currently, he is the president of Indian Psychiatric Society Madurai chapter. His areas of interest are neuropsychiatry, geriatric psychiatry, and forensic psychiatry. Our next chairperson, Dr. R. Sabreen Sajeev Rose, sir. He has done his MBBS in Madurai Medical College. He has completed DPM in Psychological Medicine, DNB in National Board Exams and passed in 2004. He's completed his MNAMS in 2019. He's a private practitioner since 2004. He's addressed many psychiatrists and non-psychiatrists at various forums. He was a part of the team as organizing secretary that organized 2 state-level psychiatric meets. He is the secretary for Indian Psychiatric Society, Madurai chapter. Now, I hand over the session to the chairpersons to introduce our speaker.
I welcome you all for the day 2 session and thank the organizers for giving us this opportunity to be a part of this program and listen to the whole thing. The topic for today is organicity and how to present a short case, how to evaluate. For the postgraduates, it's very important. At the same time, during exams, I guess you will know it's an organic or neuro case. But in real life, when a patient walks in, you need to differentiate or know which track to evaluate in details. So I'm sure ma'am will cover all that. With this short introduction on the topic, I'll hand over the mic to my co-chair to introduce the speaker.
Good morning. To talk this topic, the speaker is Dr. Migita de Cruz, and she has completed her MBBS from prestigious Stanley Medical College. She has done her MD Psychiatry and DM in Geriatric Medicine from Nimans, Bangalore. Currently, she is Associate Consultant at KIMS Trivandrum. She has more than 30 publications, including index journals. She has a range of interest in research from biological psychiatry, social psychiatry, and feminism. We welcome the speaker to give her talk.
Good morning. I hope everyone's had a very eventful boating. So I will be talking about the evaluation of organicity in psychiatry with the caveat that perhaps the functional organic dichotomy might not be as valid as it once was. So what do we mean when we say evaluate for organicity in psychiatry? Or what does it imply when we get a referral from the neurologist saying that this is a person with altered behavior, please rule out organicity? Organicity is a term that is no longer formally recognized by recent schools of thought in medicine or psychiatry. It is a former term to imply that there is a demonstrable biological dysfunction in the brain, either because of a primary disease in the brain, such as, say, Alzheimer's dementia, or because of a secondary condition, such as hyponatremia leading to delirium. Now, the evaluation of organicity is based upon the functional organic organizing principle, which means that broadly, whatever comes to the psychiatrist can be put into 2 categories. One is functional, one is organic. Functional disorders are disorders in which the brain looks about normal. Structural imaging is fine, functional imaging is fine, except for a few abnormalities. And on the whole, there seems to be no clear understanding of how the disease evolves or how the treatment works to help the brain. Which was the case, of course, before the advent of neurobiology, before we demonstrated that neurotransmitters and the modulation of neurotransmitters underlies the treatment of psychiatric disorders. Organic disorders, on the other hand, are conditions in which the understanding is that based upon symptoms, signs, or syndromes that the patient have, we can come to a very specific demonstrable biological diagnosis. What are the advantages in organicity? Simply put, as psychiatrists, it's reassuring for us. For example, knowing that there is a definite cause for the dysfunction makes it easier for us to communicate to families. It might be easier to say that there is a thyroid disorder and that is causing the current presentation, rather than saying that there is a functional disorder, and therefore might be easier for families dealing with stigma to form a relationship with the treating team. So as an entry point, it becomes easier both for the clinicians and for the families. Obviously, if there is a secondary cause, we would want to identify and treat it, because until then, whatever medication we give to manage the behavioral dysfunction would be symptomatic. So clinically, when would you want to suspect organicity? What I have found is that while we are given a number of pointers to look for organicity in our training program, clinical practice is often very different, and sometimes there might be people without any indicators of clinical suspicion who turn up incidentally to have primary or secondary disease, which can explain the presentation. And while it's useful to know of certain markers for organicity, it's also important to keep in mind that a person might present without any of these signs and symptoms and might still have something wrong. So sociodemographically, you would say the major reason we want to evaluate for organicity is to know how far we should work up the person, how far should we investigate, how far should we keep looking for a cause before we can give a diagnosis to the family and initiate treatment. And that also depends upon the kind of practice that we are doing, based upon the kind of resources that the hospital has and the patient has to look for a diagnosis. So sociodemographically, bearing in mind that most of our severe mental illnesses, schizophrenia, bipolar disorder, and recurrent depressive disorder, these are conditions that generally manifest in early to middle adulthood. So any onset which is outside the usually noticed stages, that is a pediatric onset, an onset of a mental illness before the age of 12, is worthwhile investigating for organicity. That, of course, is beyond noticing that you already have conditions where there is neurodivergence, ADHD, autism spectrum disorders, and intellectual developmental disability. Similarly, in disorders where there is a late onset, primary psychotic illness meeting the signs and symptoms of schizophrenia, which between the ages of 40 to 60 would be called late onset schizophrenia. Above the age of 60, based upon the recommendations of the international consensus criteria on late onset schizophrenia, the disorder is considered a very late onset schizophrenia-like psychosis. The recommendation by the international consensus criteria is that any disorder which appears like schizophrenia for the first time after 60 is very, very unlikely to be a primary dopaminergic deficit, but is much more likely to have a alternate etiology and therefore should be evaluated extensively. Similarly, for mood disorders, a new onset of a bipolar disorder after 50 years of age, a new onset of a depressive disorder anywhere between 50 and 65 years of age. In terms of clinical history, any atypicalities in the history, for example, a continuous course where you would expect an episodic nature, such as a recurrent depressive disorder, a clinical course with changes. For example, in the frontotemporal dementias, you might initially have a change in behavior and personality, followed by, say, some repetitive compulsive behaviors, which are often diagnosed as OCD, followed by a decline in language. So when it looks like a person is having different diagnoses at different points of time, it's always a good idea to look for organicity. Similarly, when there are atypical symptoms, generally the dictum, for example, is that visual hallucinations are very unlikely in schizophrenia. So a person with schizophrenia who has hallucinations in other sensory modalities, visual hallucinations, tactile, olfactory or gustatory hallucinations, also worthwhile looking for organicity. And of course, any disorders in which there is cognitive impairment, any disorders in which there is a change in personality. bearing in mind that most disorders in psychiatry are lifelong syndromes, you would be following up the person over a period of time, and there will be changes with long-term mental illnesses, even if it is in remission. So persons are likely to have impaired attention, impaired concentration. There might be a decline in biological, social, and occupational functioning. And you might notice that the functioning is a little different from people who are unaffected, of the same age, of the same gender, and the same socio-demographic group. So slight cognitive impairments are to be expected. Similarly, patients with long-standing mental illnesses are much more likely to develop degenerative conditions late in life. So 40 years of schizophrenia means you are about 8 times as likely to develop Alzheimer's in late life as a person without a mental illness. But despite that, if there is significant cognitive impairment, that is, if there is cognitive impairment which is severe enough to affect the person's functioning, and if the cognitive function is declining quite markedly over time, always a good idea to look for organicity. Similarly, any sort of change in personality, even though it may be explained by the experience of living with a mental illness, should never be taken as such and always warrant evaluation. So what are the things that you would look at in the history of presenting illness? From the exam point of view, apart from looking at the person's emotions, apart from looking at their cognitions and behaviors, you would also always want to look if there is a history of falls, of injuries. Something that I have personally found is with head injuries, we always look for whether it is significant. That is, if there was a loss of consciousness, if there is amnesia for the period, or if there is a sign of raised ICT. But recurrent minor traumas are also significant enough to cause damage to the brain over a period of time. So say chronic alcoholic with repeated road traffic accidents, a person with Parkinson's disease who has repeated falls in the bathroom. Demonstrably, each time you evaluate the patient, CT brain looks fine, but over a period of time, the concussions build up. And there is a higher rate of degeneration that is noticed. So anybody who has repeated falls or injuries, even if they look benign, should always be evaluated more extensively. Similarly, if you have a movement disorder, if you have a sleep disorder, or if there are signs of autonomic dysfunction, including things as trivial as a long-standing constipation. Most importantly, because especially in Parkinson's, as we know, the non-motor symptoms such as a REM behavior disorder or constipation can precede the onset of tremors by up to 20 years. So you might symptomatically be treating the person with benzodiazepines, and then about 20 years later, they might develop a new onset tremor. Always a good idea to look for comorbidities. The more comorbidities a person has, the more likely it is, again, that something may be contributory. For example, right now in the hospital, we have a 81-year-old man who has been under treatment for Parkinson's disease. And along with the Parkinson's has a REM behavior disorder, which we were treating. But then the RBD turned out to be very severe and quite resistant to medicines. So he didn't respond to benzodiazepines, didn't respond to the Z drugs, didn't respond to atypical antipsychotics, to melatonin. Also, he had a long-standing constipation for a long time, which was considered insignificant because you expect constipation in Parkinson's. Eventually, what happened is CT abdomen found mass at the confluence of the biliary ducts. It was a cholangiocarcinoma. And on subsequently doing a paraneoplastic workup, we found that he had autoimmune encephalitis, which was explaining the current presentation of treatment-resistant insomnia. Here, the reason we started evaluating is because the insomnia was not responding to most medicines that you would expect a response to. But always a good idea to keep in mind that even if a person has one diagnosis which might explain the presentation, a good idea to look if they have other conditions which are also contributory. Similarly, occupational history. So, an occupational history where there is an exposure to petroleum products, an exposure to air pollution, working with silicon materials, working with construction material. A personal history where there is an indicator of high-risk behaviors, such as, say, not just high-risk sexual behaviors, but also high-risk interpersonal behaviors. For example, driving very rashly, getting into quarrels, something which indicates impaired frontal lobe functioning, impaired impulse control. An onset in the postpartum period, an onset which occurs late in life coinciding with menopause, all of which indicate that there are physiological events corresponding to the onset of the mental illness. In terms of examination, I think very, very important to not overlook the basics, which is again something that all of us know. People are often reluctant to disclose a substance use history, unless, of course, the consultation is for alcohol use. So we have often had patients who are admitted for, say, a coronary angioplasty, post-operatively develop delirium tremens with tachycardia, and on evaluation is when we find out that the person has had a history of alcohol use. So monitoring the pulse and in case of any tachycardia, always asking for substance use is helpful. Similarly, asking for stimulant use history. Methamphetamine, for example, is very, very common right now, and it is not uncommon to see persons presenting with an acute psychosis. On evaluation, even if nothing looks indicatory, a good idea to send a urine examination and look for products of metabolism of methamphetamines. Again, methamphetamine intoxication is something which will also present with tachycardia and hypertension, unexplainedly so, especially in young adults. Similarly, any abnormal systematic finding whatsoever. For example, the more chronic degenerative diseases a person has, the more likely that they will eventually develop a dementia. So, long-standing diabetes, hypertension, coronary artery disease, multiple angioplasties. And if you have a cognitive impairment, you know right at the beginning that there's likely to be at least a partial vascular etiology to the cognitive impairment. So the more comorbidities there are, the more likely it is organic. The more comorbidities there are, the more likely that the eventual diagnosis will be a vascular dementia. The presence of any minor physical anomalies, of marfanoid habitus, of asymptomatic hyperbilirubinemia at any age. The presence of sensory impairment, of hearing impairment, of visual impairment. Again, because sensory impairments correlate with cognitive impairment. And in many cases, the cognitive function might just improve by treating the auditory or the visual disability. And looking for any inflammatory conditions. So, say somebody who's got frequent hair fall, photosensitivity, swelling of joints, dryness of the conjunctiva, dryness of the oral cavity. Again, a very good idea to look for autoimmune conditions and for inflammatory conditions. An important thing to note in mind is because South India is a tropical region, our metabolism is going to be far more rapid than the temperate regions. So obviously what you're going to see is we are going to develop free radicals more often. Metabolic aging is going to be more rapid, and therefore we also have a higher susceptibility towards autoimmune and chronic inflammatory conditions. Bearing in mind that it might not just be the climatic conditions, but also our socio-cultural environment which are contributory, there is definitely a higher incidence of autoimmune and chronic inflammatory conditions in our part of the country when compared to, say, the global north. So, once a person comes with a mental illness, or once a person is referred to us by another specialty, we run a whole host of tests, and then you find several things that are abnormal. For your example, you might find chronic renal impairment, you might find hyponatremia. Once you find all of these, how do you put them together? How do you say which of the organic workups that we find are contributory and how many of them are incidental? That is the point at which you would want to form a hypothesis. Obviously, the go-to for organicity is Leishman's textbook, and therefore I would recommend going back to Leishman's criteria. That is, organicity can be suspected in any condition where there is a high probability that on examination and investigation you will find systematic pathology. And therefore the ICD criteria are useful. So Is there a temporal association between the workup and the presentation? For example, in a person presenting with acute psychosis and hyponatremia, was there a long period where they were living alone? Was there a period in which there was a decreased oral intake? And therefore, can you say that the hyponatremia probably started before the acute psychosis? How plausible is it that the current condition may be caused by the finding? Uh, for example, if you have an autoantibody positive, it explains just about any neuropsychiatric manifestation the person has. In a person with, say, Gilbert syndrome who has only congenital hyperbilirubinemia, it might be unlikely that it is the cause for a recurrent depressive disorder. And look at the but for condition, that is, but for the hypothyroidism or but for the cerebrovascular accident, would the person be presenting to you? Would the person be having this? The fourth criteria is the most deceptive because we often believe that withdrawing or treating the offending agent might cause an improvement or remission. Ideally, that should happen. For example, in pellagra, when you're treating the niacin deficiency, there should be an improvement in delirium, should be an improvement in cognitive functioning. But then the longer the organicity has been untreated, the more likely there is to have been chronic brain damage. And in somebody who has at least a moderate to severe illness, it is very likely that the person might only become partially better with correcting the organicity, and the remaining issues would have to be treated behaviorally. Let us treat a psychotic symptom with antipsychotics, treat mood symptoms with antidepressants or mood stabilizers. So, even after identifying the organicity, very important to continue treating the person in a manner similar to the primary psychiatric diagnosis. The only difference would be that we would use a smaller amount of the psychotropic because the person is likely to have a smaller requirement. And though we are looking at a biological hypothesis, also a good idea to at some point come back to a psychodynamic formulation. So once we summarize the case and we identify the organic factors, to also look at the psychodynamic factors operating in the environment. For example, why now? In a family where there have been issues due to a person with behavioral symptoms over a long period of time, why are they coming to us right now? What has changed? What has changed in the family structure? What has changed in a person's current presentation that has led them to come? Because in most cases, the duration of untreated illness is at least 2 years. So if there has been a change in the way the family is coping, something must have changed. And finally, to look at how the organic factors as well as the psychodynamics of the patient, the family, and the community will affect the treatment and the prognosis. So, practically, when you work in consultation licensed psychiatry, I think you're likely to come across 6 categories of conditions. The most common are psychiatric presentations of medical conditions. For example, a person with say again a hyponatremia or hyperthyroidism presenting as an acute psychosis. Or it's possible to have a psychiatric complication of a medical condition or treatment, delirium post-CABG. Psychological reactions to medical conditions or treatment, such as a catastrophic reaction and an acute stress reaction to finding out that one is HIV positive or one has a carcinoma. Medical presentations of psychiatric conditions, for example, eating disorders, cyclical vomiting syndromes, usually present initially with dehydration and as a gastroenteritis. It's only when you stabilize the patient and hydrate them would you find that you're not able to identify an etiology for the vomiting. And then perhaps some probing is when the eating disorder or the cyclical vomiting might emerge. Similarly, conditions in which there is a comorbid medical and psychiatric diagnosis. So, a person with a long-standing bipolar disorder who now has a new onset Parkinsonism, and therefore both need to be treated together. What are the tests for organicity? Like the term organicity, the organicity test is also a term which is now obsolete. But these are tests which are intended to identify a demonstrable pathology either in the brain or in the peripheral system. So practically, when we suspect organicity, based upon the resources that both the hospital and the community have at their disposal, you would want to look at toxicology, screening for heavy metals, screening for substances of use, uh, looking for a past history of overdose, either of prescription medicines or of substances. Looking at serology, so HIV, VDRL, hepatitis B, hepatitis C. In fevers of unknown origin, to often look for a comorbid cryptococcus or pneumococcus infection. To look at endocrine causes. Also important to notice that what we have seen frequently is Addison's disease very commonly coexists with hypothyroidism. So where a person has one endocrine dysfunction, it is very unlikely that it stops over there. They are likely to have multiple other conditions, and a good idea to look for them. Especially the dictum being that the kind of cases they present to a hospital are going to be the most severe cases in the community. And the more severe cases and the more acute the presentation, the more likely there are to be at least 2 or 3 conditions on evaluation. Obviously, look at nutritional causes. For example, a vitamin D deficiency is found in about 80% of the community now. That is despite an adequate nutritional intake, despite adequate sunlight exposure. So clearly, perhaps the changes, climate change, perhaps it's global warming, perhaps it is the greater amount of particulate hydrocarbons. But definitely, we are seeing a very high prevalence of vitamin D deficiencies. This is over and above, obviously, looking for B12, folic acid, and other water-soluble vitamins if possible. Neuroimaging, that is, again with an acute presentation, if possible, to look at a CT brain. If there is a facility for detailed evaluation, at least to consider an MRI brain. And electroencephalography, again, is a very good idea to combine with imaging. Because while neuroimaging might tell you what the brain looks like at a particular point in time, the EEG gives us an idea of how the brain is functioning. And random epileptiform discharges or random frontal spikes might be found in an otherwise unremarkable case. And that itself might be an indicator that there is an encephalitis ongoing. Again, wherever possible, to look at the CSF analysis to identify inflammatory conditions, to identify autoimmune disorders. Practically, what we are seeing is about 40% of the tests for an autoimmune disorder in the hospital come back positive. Even in patients who are, autoantibody positive, if the presentation is with an encephalitis-like picture, the general dictum in our department of neurology at least is to treat it as an autoimmune encephalitis unless otherwise proven. So treat them with IV methylprednisolone with IV immunoglobulins, and in most cases there is a clinical improvement. Since about 60% of autoimmune encephalitis is seronegative, always a good idea to treat undiagnosed cases as autoimmune encephalitis, and perhaps also to treat for a possible herpes simplex infection and for possible tuberculosis. Prior to the advent of widely available serology and imaging, the predisposition in psychiatry was to run bedside screening tests for clinical psychology. That is, look at neuropsychological evaluations which might help us identify an organic etiology. And therefore, tools like the MMSE or the HMSE are useful for bedside screening. While the Addenbrooke's is a more detailed assessment, very important to note that the only confirmatory neuropsychological test is a comprehensive neuropsychological battery, traditionally Luria or de Halsted. And of course, we have adaptations in the Indian context. So the PGI, AIMS or NIMHANS batteries are again useful. But before categorizing a person as having an organic etiology, the only confirmatory test which can be done is a detailed neuropsychology assessment. A couple of tests which are of historical importance and might be useful for exam-going PGs are the Hoffman's test. Hoffman's test is a condition in which the person was asked to pair rhythmic patterns with geometrical designs. So they would be presented with different images of designs with different objects, and would have to produce a rhythmic pattern. The principle was that the first ability which is lost in an organic condition of the brain is the innate ability to understand rhythms. Another test was Eliza's test of psychoorganicity, which looked at our visuospatial construction. Hoffman's and Eliza's tests were useful because it was found prior to widespread neuroimaging that it helped differentiate at least 70 to 75% of cases where there was an organic etiology from cases in which there was a functional etiology. Lobar function testing whenever possible. At the very least, looking at the frontal lobe. And of course, if we find a dementia, to look at the diagnosis of dementia. Again, the clinical dementia rating scale is the only tool which is a diagnostic tool for dementia. Everything else is just a screening instrument or a severity rating scale. If there are neuropsychiatric symptoms, to look at the neuropsychology inventory. And especially in geriatric depressions, to use a specific geriatric depression scale. If a person has multiple comorbidities, regardless of the etiology, to always apply Hutchinsky's ischemic scale. And eventually to categorize functioning, because what are we hoping to achieve by treating the organicity? We are hoping to improve the outcomes. We are hoping to improve the person's abilities to functioning. And a clinical improvement does not mean much to the person or to their family unless it also leads to an improvement in their social and occupational functioning. So quantifying the degree of disability and then measuring it at follow-ups usually helps to identify if the treatment is beneficial or not. How much time do I have now? 10 minutes, no? Right. So briefly then I will go into looking at how one can approach a neurocognitive case. So in a general hospital, the most common diagnosis that we are likely to come across is delirium. In an exam clinic, the most common neurological case will hopefully be a neurocognitive disorder, that is a dementia or a movement disorder such as Parkinson's. Again, in a neurology case, while a detailed neurological examination is useful, and any reference from Hutchinson's to McLeod's to Bickerstaff is a good idea, the idea is always that by the end of the history, one should have a very good idea of what the etiology could be and to be able to come to a differential diagnosis. All the tests that we do are intended only to confirm the diagnosis. In the clinic, regardless of where the clinic is located, always a good idea to start with the patient. Usually because the patient's communication might be affected, particularly in delirium or dementia. One tendency is to turn to the caregiver, turn to the bystander and ask what happened. But a good idea to start the conversation with the patient to establish rapport. There are two advantages. One, apart from establishing rapport, the person is likely to be very easily fatigued, especially if there is another illness. And by the time we finish the history and turn to the patient, they might already have a decline in their functioning. So the person might perform best in the interview right at the beginning of the consultation rather than towards the end. Also, especially in people who are not very, say, cooperative right now to a detailed neuropsychology test, just a conversation will act as a mental status examination. And while families will always tell us where the problem started for them, a good idea to keep asking when there was any problem at all, when was the first time the problem started. Because usually by pushing into the history, you're able to backdate the symptoms to another 3 to 5 years, which changes the picture completely. Whenever possible, to link it to life events and to see if exit events have led to a decline in functioning. Again, while families might tend to tell us about problem behavior, such as he's not eating or he's urinating inappropriately, a good idea to contextualize the behaviors, to identify what kind of settings it happens in. Does it happen at sunset? Does it happen immediately after getting up from sleep? What are the person's thoughts, emotions, and behaviors? How do they respond? What is the behavioral response? What is the physiological response? And to deconstruct a deficit that is based upon the history to try to identify whether, say, it is an apraxia or an agnosia, or simply whether it's a visual or a hearing impairment that has caused the presentation. To, as far as possible, within the amount of time given to us, to make a longitudinal narrative. Because while we might have a lot of different symptoms that are presented, looking at the order in which they evolved is usually helpful. Because classically what you see, say when you're trying to differentiate the dementias, is that Alzheimer's has a long period where functioning is almost okay, followed by a slow gradual decline in functioning, and often improvement when treated with cholinesterase inhibitors. So while donepezil and memantine might cross-sectionally lead to a slight improvement in functioning in a mild dementia, when you look at a long period of time, continuing to treat the dementia often gives a person 2 to 3 years of reasonably better quality life. And therefore, there is a very good argument to be made to continue to treat a dementia even when, say, it is a moderate to severe etiology. In vascular dementias, we classically expect a stepladder pattern, which is deceptive because the subcortical dementias, the Binswanger's diseases, might just have a slow decline in functioning. But here, how you differentiate is unlike Alzheimer's, where the deficit is in, the classical amnesia, agnosia, apraxia. Here, there will be a slow decline in executive functioning. Frontotemporal dementias, where say the onset is between the age of 40 to 60, and the presentation is with a change in behavior or a loss of language abilities. Or say Parkinson's disease, where, as we looked at, constipation, RBD, and a loss of smell occurs several years before the tremors, and it takes about 17 years from the onset of tremors to the onset of a cognitive impairment. So say if there is an onset of cognitive impairments and tremors within 1 year of each other, to always consider a differential of a Lewy body dementia. Finally, in a person presenting with end-stage dementia, it might be very difficult to identify what etiology is there. And it is very, very likely that we will have more than one etiology. In which case, again, to treat the person symptomatically and to focus on improving the quality of life. I think I'll stop here for now. Sure.
We thank the speaker for giving a broad outline of assessment of organicity in psychiatry. So for a postgraduate point of view, there are two things. One is exam as well as in regular clinical scenario. In exam point of view, you will be kept in short case, neurology short case, as well as a spotter, where you will be assessed in terms of how you take a history as well as how you examine. You are supposed to demonstrate to the examiner how you are approaching a case as well as diagnosis and management issues. So clinical point of view, assessment of organicity is a routine. So any psychiatry postgraduate assessing any case in psychiatry OP, any patient referred to psychiatry OP, it is our duty that we have to assess organicity and we have to rule out. So there should be some pointers that will help us to assessment of organicity so that we are not going to miss a diagnosis. So the pointers can be in terms of historical point of view or examination or an MSc. So historical point of view, as madam has mentioned, the onset of illness, suppose an abrupt onset, a pointer towards an organicity. And the cause of an illness, presence of typical symptom, typical cause, associated comorbid conditions, or associated history of any involuntary movements or postpartum onset, all can indicate there can be an organicity. And specifically, historically, we can take history in the form of history of loss of consciousness, impairment of consciousness, fever, seizures. All this can be a historical information that we could get. Examination point of view, all postgraduates should understand that every case we are supposed to do a thorough general examination and physical examination. Many times we miss, we just conclude that it is a pure case of functional illness without doing any physical examination. So every patient should be assessed thoroughly, systematically, including a central nervous system examination, and all patients should be seen ophthalmoscopy. Fundoscopy is a must for patients, which we are regularly missing, so we are not supposed to. And MSc point of view, there are some pointers, as madam already mentioned, cognitive symptoms, predominant cognitive impairment can be a pointer for an organicity. We may be dealing with a case of an organicity, as well as certain phenomenological findings in the form of circumstantiality can also point, or perseveration can be an organic sign. So this will help. And in general hospital settings, as we see, a lot of callovers are delirium. So many times they are suspected to be psychosis by non-psychiatrists, they are being referred. So we are not afford to miss. So organicity is routine, and every case should be searched for an organicity and we have to rule out.
A wonderful presentation. Now it's open for questions.
It was a fantastic presentation. You have mentioned about REM behavioral problems and constipation. Can it become a forerunner for future organicity? And what extent it can cause? Is there any literature evidence for that?
The problem again is that most of those longitudinal studies are based upon high-risk communities or uh, based upon hospitals, where obviously these are people who are going to have more severe disorders. Functionally, Parkinson's has been found to be much more common than uh, we have once suspected. A REM behavior disorder implicates a primary dopaminergic deficit, and in most people with an RBD, by the end of about 10 years, you would find a 60% conversion into Parkinson's. Constipation again it's a dopaminergic deficit in the peripheral nervous system, less likely. So perhaps in follow-up studies, 20-30% might have had a movement disorder. But again, these are studies which are based in populations where there was already a very high risk, or populations around the community, populations in a OPD. So in the community, it might be much lower. On the other hand, what I found is if there's constipation, always a good idea in the hospital to evaluate further.
So given us a short case, there is no other finding other than disorientation alone. So other findings are more or less in favor of a psychotic condition. But in MSc, there is gross disorientation. Where to err?
If the presentation is delirium, what to do?
Much delirious. Everything okay, but totally little delirious.
Always in a neurology case, a good idea to begin with a differential diagnosis. If it is a pure circumscribed delirium, a good idea to rule out Ganser's dementia, to look for inconsistencies, to look for fluctuating levels of orientation, approximate answers. So Ganser's dementia is one potential possibility. Alternatively, to just say delirium or a mild cognitive
very young
impairment.
individual.
In a neurology short case, the focus would be delirium under evaluation to be worked up further. In a clinic, immediately the thought would be to look at a meningoencephalitic workup, especially if it's a young person and there's an acute onset.
For a PG, given as a short case, where can the diagnosis be fixed, and what is, we don't have time to do all investigations like that.
That is the point at which a differential diagnosis would be useful. And in that case, just saying dementia under evaluation or delirium under evaluation, and these are the tests that I would want to do further. These are the possible etiologies that I am suspecting based upon the examination and the findings.
PGs requesting you to clear your doubts.
So, my first question would be, what are the benefits of an organicity investigation? And which of the following is not a benefit of the workup for organicity? So, a technical tool for families, a relational tool for patients and families, seeking an accurate somatic assessment, or pragmatic patchwork.
Name?
Pragmatic patchwork.
So pragmatic patchwork is a direct outcome of organicity, where the psychiatrist treats the underlying condition for organicity in a resource-poor setting. Which of the following is now a confirmatory neuropsychological test for organicity? No, that is a very common mistake. because Addenbrooke's is a detailed assessment, everybody thinks it is diagnostic. It is not. Addenbrooke's, like the HMSC and the MMSC, is a screening tool. It is only always going to be a screening tool. And on serial testing can be used to look at the severity, never diagnostic. Hoffman's again is a test of historical value, no longer valid. Bender-Gestalt. Right now, say, if we have no other facilities available, the Bender-Gestalt test. The Bender-Gestalt test, where the person is asked to reproduce 8 visual designs from memory, is the single most sensitive test in picking up organic etiology. Usually, neuropsychologists, before beginning a neuropsychology battery, begin with the Bender-Gestalt. Because with the Bender-Gestalt, you get an idea of what the person's functioning is, and you can decide which test to do further. Addenbrooke's is never confirmatory. So one of the benefits with a neurological longitudinal history is that you can roughly identify, localize and lateralize which parts of the cerebral cortex are involved. So rules of language are localized to which of the following? The left temporal and parietal cortex, the left prefrontal and medial temporal cortex, the left parietal cortex, or the left parahippocampal gyrus. The left parietal cortex, rules of language. So, while language is generally a left parietal and temporal function, music is a right temporal and parietal function. The rules of language are stored in the left parietal cortex. The rules of music are stored in the right parietal cortex.
We'll close session now.
I request both chairpersons to honor Dr. Migita ma'am. I invite Dr. Bhagyashree Devi ma'am to honor Dr. Ananda Krishna Kumar sir, and I invite Dr. Sriram sir to honor Dr. Sabreen Rose sir.